All right, while we are waiting to get the other slides up, I also want to mention, we did mention a thank you to our sponsors. I didn't specifically, our co-sponsors, I didn't specifically mention that we're talking about Clearview treatment programs. You can meet their director, Michael Roy, and other representatives there. Also Silver Hill Hospital, where we have Amy Grimaldi, who can orient us. Not sure where we're stuck.
I don't know why. Hang on.
Okay. While we are sorting this out, I will mention that our next presenter, Dr. Anthony Rocco, is an assistant professor of psychology at the University of Toronto, where he's the director of the Clinical Neurosciences Laboratory. He's an affiliate research scientist with the Toronto Centre for Addiction and Mental Health. He's a prolific researcher. He is clearly an up-and-coming, going to be a leader of our field, particularly with regard to neuropsychological impairment within borderline personality disorder. He's already well established with grants, and we are delighted to have you with us. Dr. Anthony Rocco. If you get forward and you can put that on, is that one?
Let's see if it's
Let me just.
I guess I'll put it on this side. Sorry, give me a moment here.
Should be good.
All right.
Pointer.
All right. Thank you very much. Sorry for the quick delay there. It's very nice to be here today, and thank you for inviting me. So my name is Anthony Rocco, and I came in from Toronto last night to be here today to talk about some of the research that we're doing in my laboratory at the University of Toronto. So I should say at the outset that I am a clinical neuropsychologist, and it was really nice to see that the theme of this meeting was cognitive disturbances in BPD, and this is actually the area that I specialize in as a clinical neuropsychologist. So I recognize that many people may not be so familiar with what I mean when I say neuropsychological functioning, so I'm going to review a little bit today about what neuropsychology is and why neuropsychology may be useful for people with BPD. And then talk a little bit about how this might impact treatment and some of the research that we're doing funded by the American Foundation for Suicide Prevention that helps us potentially understand how cognitive dysfunctions might impact treatment for people with BPD. Okay, so when we talk about BPD, there are a lot of different ways, and actually Gabrielle did a great job describing the different core symptom dimensions of the disorder. I like to think about the core symptoms as revolving around 3 domains. We can talk about the interpersonal, the emotional, but I want to highlight impulse control because that is actually one domain of neuropsychological functioning that neuropsychologists like me use when we evaluate a patient. So it could be somebody with dementia, a traumatic brain injury, schizophrenia. We use cognitive tests, neuropsychological tests, to actually measure impulse control. So you can bet that I'm going to be talking a little bit about what do people with BPD look like when we're talking about their impulse control on these standardized tests. And one thing that I want to point out at the outset is you've probably heard the word cognition before as it relates to BPD. You've probably seen it in the DSM-4, that there are difficulties with cognition. Actually, it could be a component of any of the personality disorders. But cognition in the DSM-4 is actually referring to something different from what neuropsychologists typically associate with cognition. So in the DSM-4, we're normally talking about cognition as a way that people view the world and themselves and the future. This is different from what we mean as neuropsychologists when we talk about cognition. So in the DSM-4, cognition is referring to things in BPD like an unstable self-image, idealizing, devaluing others, paranoia when under stress. These are different from what we mean as neuropsychologists. So what do I mean? Well, we're talking about thinking abilities, broadly speaking, in neuropsychology. And so we use these very sophisticated instruments, neuropsychological tests, to evaluate thinking abilities. And I should point out that all of these tests that we use have been standardized so that they should be administered the exact same way every time that the test is actually given to somebody. And we actually figure out what's normal for any given individual by giving these tests to hundreds, if not thousands, of different people to see what's average and what's maybe superior, so above average, or below average, or even a deficit or an impairment. And these tests can be used with all kinds of different people, people who are, in adulthood with possibly a neurologic or a mental illness, or we could be using these with children to evaluate ADHD, for example. So what are the different types of neuropsychological or cognitive abilities that we typically evaluate as neuropsychologists? So I should point out, first of all, that these are all coming from the brain. Okay, we assume that these are the tests that we give of these different abilities are all correlated with specific parts of the brain, and different brain systems are coordinated and involved in a lot of these different abilities. So for example, one thing we talk about is attention, which is hopefully what I've got here today, right now, is your attention. Working memory, so your ability to actually maintain the information that I'm telling you now in your mind for brief periods of time. Episodic memory, that's your memory for things that you may learn today and then be able to recall them tomorrow. You've probably heard of the term executive function, and it's actually a complex term that I'll be talking a little bit more about in a moment. And it's basically a term that refers to higher level thinking abilities that rely on a lot of these other functions. And this is something that's particularly relevant to BPD, so you'll be hearing me talk about this more in a moment. We also have visual spatial abilities, so if you're able to navigate the streets to get here today, then you've probably got intact visual spatial abilities. Motor abilities, like tapping your fingers to your thumb, and then perceptual abilities, so being able to perceive things in your environment. Now, some of these things are going to be more relevant to BPD, and some of them will not be as relevant. But I want to point out that we usually evaluate all of these domains to try to figure out how they might be impacting somebody's life. Okay, so I had to strike a balance here between actually showing you the tests that we use to evaluate these abilities and protecting their confidentiality and privacy, because most of them are copyrighted tests. But I want to give you a flavor of what we typically do to evaluate these domains, and then I'm going to go into talking about what do we actually see in people with BPD. All right, so when we're talking about attention and concentration, one test for me here would be seeing, is anybody dozing off? Hopefully you're not, and you're paying close attention to this. Brief attention is one aspect of attention that we measure. This is actually looking at things like asking you to repeat a series of digits. So I might say 4, 3, 9, 7, 2, and then you'd have to repeat it back to me. So this is a measure of brief attention. So you may have heard of this type of a thing as a measure of short-term memory. That's okay to say that. Many people use that term for this type of a test, but we're usually referring to, as neuropsychologists, this is an attention test. All right, sustained attention. This is obviously the ability to sustain your attention for long periods of time. So we often use computerized tests where we ask the person to sit in front of a computer and look at a series of things on the computer screen, and we want to see how well they can maintain their attention. So for example, paying attention to letters presented on a computer monitor. You may have guessed that this is actually one of the tests, actually the Conners Continuous Performance Test is one of the tests that we use to diagnose, as part of the diagnosis for ADHD. So if you're going to see a neuropsychologist for a diagnosis potentially of attention deficit disorder, this is one way that we objectively measure attention. So I want to show you a quick example of how this test works. Actually, I'll be showing you in a moment. It looks like it is not here. Okay, I'll show you in a moment. Hopefully it's somewhere there. Verbal and visual memory, another important aspect of neuropsychological functioning. So what we have here is first verbal memory test that we usually ask somebody to remember a story or a list of words, and then maybe half an hour later remember what the words were or the story. Visual memory tests, as you might imagine, require you to reproduce a design for memory. So this is something that people really get overwhelmed by. I had a picture here of the actual complexity of trying to reproduce from memory a complex design. It's actually not that easy. Now, another thing that we do is we have something called executive functions. Now, executive functions, as I said, it's a complex term. We usually call it an umbrella term for a lot of these very high-level cognitive abilities. So these are things like planning, problem solving, and impulse control. So seeing what I say here about executive functions, you can probably guess right now that this is one of the cognitive abilities, neuropsychological abilities, that tends to be impacted in BPD. This is the most common one. And I'll talk about what these results are in a moment. So how might you use neuropsychological testing? So there are lots of different uses. I've seen people with all types of cognitive dysfunction, so people who come in with brain injuries related to playing hockey or soccer. I have people coming in to get a more refined diagnosis of dementia. So is it dementia associated with Alzheimer's or depression or both? But probably what I see the most when it comes to BPD is people talking about being worked up for a diagnosis of ADHD or a learning disorder. So this might ring true for people in the room in terms of having this come up for people with BPD. Another important piece of this is treatment planning. It's really important for a clinician to know, does somebody have really significant memory problems? Because if they do, then maybe we should be accommodating these by maybe using memory aids in psychotherapy, or maybe giving them memory aids to take medications. I mean, these are important things that we might be kind of ignoring that could be important and impacting somebody's treatment. And later I'll be showing you some cases where this definitely seems to be the case, that these types of problems are actually impacting people's ability to engage successfully in psychotherapy. Okay, so why do we care about cognition in BPD? It's probably a question that many people ask. Well, historically, if we look at some of the writings, early writings of people with BPD or that were suspected of having BPD, there was a lot of talk about problems with integrating information and that these types of things might interfere with treatment. And so recent research actually suggests, well, first of all, that if we look at people with BPD who are being seen on an inpatient basis, presenting for, really in crisis situations, that the two strongest predictors of who those people end up being with BPD those two strongest predictors of being seen for inpatient psychiatric hospitalization are suicidality and deficient cognitive functioning. And a very recent study showed that neuropsychological functioning, so performance on these types of tests, actually helps us understand who's going to drop out of treatment. So I'll be talking a little bit about that in a moment. Okay, so some of the cognitive difficulties that we've heard talked about in the literature in these kind of descriptions of BPD have been things like poor focus and concentration, problems with memory, or if they are remembering things okay, then maybe they're somewhat distorted. And we'll talk about what this actually looks like in a moment. Impulsive behaviors have been described, not surprisingly, and difficulties with logical reasoning. So when we talk about cognition in BPD, I often get questions from family members, especially from parents who have a child who's affected with the disorder, asking about the relationship between ADHD and learning disorders and BPD. And they do share several features, actually. So on the surface, they share things like impulsiveness, emotional instability, difficulty controlling anger. These are things that on the surface look very similar between the two disorders. And interestingly, children who have ADHD have been found to be 5 times more likely to develop BPD in adulthood. So there are good reasons to suspect that maybe some people with BPD have difficulties with some of these cognitive functions. Now, I often get the question as well, do people with BPD, what's going on with this relationship with ADHD? If you have ADHD, are you more likely to have BPD? Or if you have BPD, are you more likely to have ADHD? Well, the way I like to look at it is that the brain systems that are involved in regulating emotions, which we often associate with BPD, are very similar. They overlap considerably with a lot of these cognitive functions that I just talked about: attention, concentration, problem solving, and memory. And so this is a recent study that got a lot of media attention, where I actually put all of these studies together that have been done on BPD and brain imaging, and while people are processing negative emotions. What I found when it comes to parts of the brain that are underactive is that the dorsolateral prefrontal cortex, which you see here in blue, the blue little blobs here, means there's less activity for people with BPD. And then you have something called the subgenual anterior cingulate, which is right over here, another little blue blob. These are toward the front of the brain and tend to be associated with, obviously, regulating emotions, but also with attention and problem solving and a lot of these executive functions. So really, these same brain systems are involved. So I don't like to see things as ADHD versus BPD, but the parts of the brain that tend to be not functioning in the same way as they are in healthy individuals are involved in attention and emotion regulation. And it's okay to think of it as ADHD and BPD, but I like to encourage the people that I see to think about these all being related to each other. Okay, so we finally get to the slide that I wanted to get to after talking about all of these cognitive functions. What actually do we see in people with BPD? So one thing that I want to point out here is that this is basically a synthesis of 11 different studies on BPD that looked at neuropsychological functioning. But this is, remember, while people are not emotionally dysregulated. This is when people are stable and being asked to complete all these different tasks. So this doesn't account for what happens when somebody becomes emotionally dysregulated. So at baseline, what we see across these 7 different cognitive domains is that, first of all, I should say that all of these cognitive domains, attention, processing speed, so this is how quickly can you actually process information, verbal memory, visual memory, your visual spatial functioning that I talked about, kind of navigating yourself, cognitive flexibility, the ability to change your mind, and planning. These are all actually somewhat less efficient in people with BPD as compared to individuals who don't have BPD. So all of these deficits, I like to call them inefficiencies because they're not real deficits, they're not strong enough to be deficits, are significant. They really do exist in the world. But where we see the greatest difficulties, believe it or not, are with visual memory, which surprised a lot of people when this study came out. This has to do with, remember, drawing something and then remembering maybe 20 minutes later, what is it that you just drew? And it's amazing to see what people actually do. Some people really can't even remember at all that they even drew something previously. And those who do tend to really have distorted images. And again, I would show you a little bit more of some of these things, but they're copyright tests. And then planning is something that wasn't necessarily surprising here, that we actually have tests where we have somebody build a tower, for example. It's called the tower test. And what you do is you ask them to place these blocks and build this tower, and we can measure how efficiently they're basically solving this problem. And what we found is that they have a hard time really planning out what they're doing. So this was the first time that we really see evidence for clear difficulties when somebody is emotionally stable. Somebody with BPD is emotionally stable. Okay, so then the question becomes, well, how might these types of things affect treatment? Unfortunately, we don't know very much just yet. I mean, a year from now, I'd love to be able to talk to everybody about the results of this study that we're doing in Toronto, looking at treatment and how these types of things might affect treatment for people with BPD. I do have a little bit of information that I'll tell you about in a moment. But if you think about these types of cognitive abilities that I just described, if somebody with BPD is going to effectively engage in treatment, well, it's important that they're able to pay attention, right? important for anybody to be able to pay attention if you're going to engage in something as complex as psychotherapy. You should be able to concentrate. You should be able to remember what you did in treatment. What happens if somebody comes in and you as a therapist have just spent, an hour talking to them and processing a number of different important parts of this psychotherapeutic interaction. Maybe if it's a DBT type of therapy, then maybe we're talking about skills that they should be implementing in their daily lives. What if they forget everything once they leave your office? I mean, this is an important thing to consider because it's completely possible that this is what's going on. So memory, obviously important, and executive functions. If you're going to use what you learned in psychotherapy, and this is assuming that you attended to it and remembered it, you have to be able to problem solve in those particular situations. Maybe use these skills you've learned to control your impulses, to plan out what you're going to be doing. These are all really important. And it's kind of surprising we know so little. Nobody's really looked at this with BPD. And a problem can arise when any one of these specific cognitive functions is affected. So if you have a problem with attention, then you probably can't remember what it is that you were supposed to be paying attention to, and that will affect whether you can actually use what you learned in treatment. So I want to talk here now about some case examples because we don't have data just yet about how these things affect treatment. But what I'm going to be talking about are some individuals who were referred to me for neuropsychological testing as part of their workup for DBT at the Center for Addiction and Mental Health in Toronto. So before I go into the details of these individuals, I want to refresh people or teach people, if you're not familiar with it just yet, how we actually gauge how good somebody is doing on these tests versus how not so good people are doing on these tests. And we call these Z-scores, or if you're from Canada, we call it a Z-score. So if I say Z, just deal with me. So I want to refresh people's minds for those who may have learned this. A Z-score is a score that we use that helps us understand where an individual person that I have in my office, where do they lie with respect to the general population. So like I said, these tests have been given to hundreds, if not thousands of people, so we know what's average, and we know what's not so good and what's really good. So an average score, I should say, is 0. Okay? A Z-score of 0 means you're right in the middle, 50th percentile. As neuropsychologists, unfortunately, we're looking for the lower end of things. And, are there certain problems that might be explaining, why somebody isn't getting better in treatment? So we usually look for a Z that's less than negative 1.5. If you think of a bell-shaped curve, it's kind of on the low end of this. So as you're looking at the people's results that I'll be presenting in a moment, I want you to look for a Z of negative 1.5 as an indication of, we actually would call that a significant deficit for an individual person. Now, anything above that, you can see ranges from low average up to average and then even superior. So keeping this in mind, and you all have it in front of you so you can refer to it, I want to first talk about a male that I just saw probably 3 months ago. He was a 25-year-old young man, a really, really sweet guy, in his 3rd year of college, and he was, again, referred for DBT because of extensive self-harming behaviors, notably cutting, and also making suicidal threats to a number of different people. So he eventually was hospitalized, and he was hospitalized for so long that he decided to drop out of college because things were just too difficult to manage at that time. So he came to see me, and he really presented as very anxious, really wasn't sure whether he wanted treatment. It was so hard for him to get treatment that he was at the point where he's like, okay, I guess I'll kind of give this a try. I'll go through this assessment, and then we'll see where I am, and maybe I'll commit to treatment, but maybe I won't. So he talked a lot about a history of parental abandonment. His father left his family when he was a young child, and he talked, unfortunately, a lot about extensive physical abuse, which he said was at the hands of his mother, and that a lot of this has shaped kind of the way that he relates to people now, especially women. So he has a lot of social anxiety toward women. So in addition to BPD, he was diagnosed with recurrent major depression. We do a kind of very comprehensive workup. And he also had some difficulties with alcohol abuse in the past. When he becomes significantly dysregulated emotionally, one thing that he often turned to in the past was alcohol. And so it's important to consider substance abuse when we talk about somebody's cognitive functioning. And as I said, he was really reluctant to engage in psychotherapy for his difficulties. And I think a lot of it had to do with having so limited access to treatment in Toronto that he just didn't want to even, at this point, unfortunately, really fight for the treatment. And we were able to get him ahead of the waiting list and get him into treatment. But first, before I talk about what happened to him, I want to talk about his neuropsychological functioning. So one thing that I want to point out is that we always get an estimate of somebody's IQ when we evaluate somebody. And one thing that I don't like to hear is a lot of people think, well, maybe, I'm just not smart enough. I'm dumb. That's what's going on here. But it's not. Actually, for him, he was still within the average range, okay? Anywhere from here to here is average. But most of the people that I see with BPD, on average, are actually a little bit higher than our healthy individuals with regard to IQ. So it's not a problem of IQ, that I don't know what to do, or I'm having, I'm not smart enough to do this. It's not an IQ problem. Instead, if we look at each of the cognitive or neuropsychological domains that I presented earlier, what we see is that, for example, his ability to process information is perfectly normal. He has good attention, both brief and sustained. Where we start to see some lower scores moving toward that 1.5 mark that I talked about is verbal memory, response inhibition, his ability to control his behavior. And what we can see is being really significantly impacted is planning. So you might think about what are some of the difficulties that you'd expect in therapy with somebody like this. What would we expect to see? Would he be planning out what he should be doing on a weekly basis? Would he be able to control his impulses as well as somebody else who maybe objectively has good impulse control? Will he be able to remember what you did in each therapy session? I think that all of this is so important when we think about planning treatment for these people. So despite his difficulties here, he actually expressed to me that he's maybe a little more optimistic this time around for treatment. And by the time that we finished our assessments with him, he really talked about being more enthusiastic about his prospects for getting better with DBT. So he scheduled his first psychotherapy session, but he didn't attend the appointment. Okay, so maybe this isn't entirely surprising considering his neuropsychological profile. And when the clinic coordinator contacted him, he basically stated that he was no longer interested in therapy. So this was unfortunate, and we're obviously still trying to get him in and seeing what we can do to kind of motivate him to engage in this treatment. But the study that I talked about, the one study that's actually been published so far on BPD and treatment, found that planning and visual memory are the greatest predictors, the strongest predictors of treatment dropout. So it's not entirely surprising when we look at how poor his planning abilities were. And by the way, this is when he's emotionally stable. You can imagine how worse things might get when he's experiencing some stress. It's not entirely surprising given the research that we actually see out there. All right, so I have a second case that I want to talk about. And this is a woman who came to see us as well for her workup for DBT at CAMH in Toronto. If you've heard of Shelley McMain is the coordinator of this clinic. And she was referred because of extensive self-harming behaviors. And she's actually probably one of my favorite people, to be honest with you, that I've evaluated. She was a really outgoing individual. And she, at first I thought it was her being neurotic. When she scheduled her appointment to come see me, she called me over and over again saying, okay, where exactly do I need to meet you? Where does the bus drop me off on the campus? Where do I go from here? And you'll see what that may have actually been in a moment, not just being a little neurotic. But we talk about her case history. she talked a lot about having interpersonal problems, going back to childhood. She said that she couldn't even get on the waiting list, unfortunately, for treatment in Toronto, and that finally getting this hope to actually get into treatment was a really, really big deal for her. And so she was excited to finally be at the end of the waiting list and to get into this treatment. So she talked a lot about interpersonal problems, unemployment, and she attributed a lot of these things to her emotion dysregulation. This is not uncommon, by the way, for us to see people who are chronically, basically unemployed, have a hard time finding work. And some of the research that we've done so far actually suggests that some of these neuropsychological deficits might be contributing to this. But that'll be a topic for another day. Now, in addition to BPD, our assessment showed that she was diagnosed with major depression, alcohol dependence. So a big thing for her when she was feeling emotionally dysregulated in the past was to turn to alcohol. And unfortunately, when alcohol was no longer an option for her because of the really harmful consequences it was having for her, she turned to her self-harming behaviors. So, you know, it was kind of the switching from one thing to another, all, in a sense, you know, forms of self-harm. She also described PTSD related to physical abuse from a romantic partner in the past, and paranoid personality disorder. So we already know that she will have difficulties with trust, you know, going into this. Okay, so when we look at her neuropsychological profile, it's quite different from the young man that I just presented. We can see here that her IQ is actually high within the average range. So not surprising for us to see people with very high IQs, yet difficulties, you know, holding a job or being able to, you know, really stick with treatments. Well, what's really going on is we can actually see a big dip here when it comes to verbal memory and especially visual memory. So we see processing speed, attention, planning, response inhibition, all intact. So what's going on? Well, the test of visual memory is actually quite difficult, and she really distorted the image that she had to present to us. She had a hard time recalling lists of words. And it's not surprising then that after completing the neuropsychological testing and I looked at the results of it, I thought, wow, she has some really significant cognitive difficulties. I should say, by the way, that we always give tests of effort. So it's not that she's just not trying. We actually give tests that see how hard people are trying. So these are all valid performances. This is actually how she does on these tests, not that she's not trying. So after she completed the testing, I got a phone call, well, several phone calls later that night and the next day because she couldn't remember if she had actually participated in a study of mine or if it was another study, and it ended up she was actually talking about somebody else's study at a completely different hospital. So I could start to see here how memory might be playing a role. And in talking to her therapist, I learned that psychotherapy, and by the way, she's been in therapy for about 4 months now, in DBT, has progressed somewhat slowly, slower than they would have liked. And one of the main themes was that she tends to leave a lot of messages for her therapist. I actually got a lot of messages too the next day saying, I forgot to tell you this, or I forgot to tell you that, right? And her therapist apparently has a difficult time kind of managing all these phone calls. So it would be nice to know how can we actually use memory aids or other types of things during the week in between therapy sessions rather than kind of calling her therapist multiple times to say, oh, I remembered this, and this is really important for me to say, right? I know that it is important, but maybe trying to knowing that these could be problems and planning ahead of time, we can avoid maybe some difficulties, and maybe psychotherapy would be even more effective. And another big thing was, not knowing how to handle a situation. I often hear people saying that I don't know what to do in this situation. And what our research suggests is that they know that it's actually in there. Their memory, even though it's not, as great as we might hope on average for these people, the information gets in there. The hard part is actually using the information. So it's not that they don't know it or remember it. The hard part is retrieving it from their memory and using it. Okay, so some of the take-home messages that I have then is that, BPD is associated with a range of cognitive deficits, and that no two individuals necessarily will look the same. Some people will have deficits with memory and concentration. Other people will have really difficult problems with planning and impulse control. And so we can't say that everybody with BPD has these problems. In fact, we found that there's a good proportion of people, I'd say a good 25 to 30% of people who don't show any significant deficits at all, actually. So this is not common across all people with BPD, and no two people look alike. But what we can say is the most frequently affected domains are memory, response inhibition, and planning. And these deficits are really subserved by many of the same brain systems that are involved in regulating emotion. So usually we're talking about frontal regions of the brain being responsible for regulating emotions. They're also involved in regulating, controlling, focusing attention. Now, we talk about treatment. Worse executive functioning and visual memory in this one study by Fertuck et al. In 2012 actually suggested that it's visual memory and these executive functions, if you do particularly worse on those, that is a predictor. It helps us understand who's going to end up dropping out of treatment, in terms of people with BPD. So it's, there might be a lot of potential here if we can actually study this in a systematic way. And I would recommend to many of the clinicians here today, if somebody comes to you and says, I do have memory problems, I have a really hard time paying attention, to trust your patient, okay? This is something, real for them and might warrant a neuropsychological evaluation. And so an individualized neuropsychological assessment might actually really assist with treatment planning and could improve the treatment outcomes for these people. And really briefly, what I want to say here is that the study that we're doing is actually looking at DBT and kind of how cognition and brain function might change through treatment. And if we're talking about DBT and the mindfulness component of DBT, that this is really an attentional intervention. Can people really use their attentional skills in a more effective way? And if somebody is having problems with concentration and distractibility, if you can actually improve their attention through some of the things that we do, as part of therapy, if you can improve attention, then actually that has a good impact on memory. You can actually improve memory as well. So there are a lot of really interesting ways that therapy can actually take advantage of what we know about cognitive deficits in BPD and maybe improve them and improve therapy, hopefully, outcomes for these people. All right, so where are things going with this research? Well, we have, as I said, this study that's funded by the American Foundation for Suicide Prevention, and we're incorporating this neuropsychological testing that I've already talked about and brain imaging to see whether we can predict who with BPD, who's also self-harming, who's going to benefit the most from DBT, and how might these things actually impact treatment? I think, an important question that hasn't been evaluated just yet. So look out in about a year or so. We should have the results of this study available, and hopefully we've got some interesting findings. And another thing that I want to talk about, because this is a study that we're running in our lab right now in Toronto, is that these cognitive deficits that we talk about in BPD might actually be heritable within families. So we have this small pilot study. We've now got probably 60 families in the study at this point. We're actually looking at people who have BPD and their first-degree biological relatives and looking at whether people who are related to people with BPD, by virtue of being genetically related to them, do we see some very subtle cognitive inefficiencies? And the long story short is that it seems that we do, actually, very subtle, not everybody, obviously, so if you're a family member here today, this is on average, okay? What we're finding is that there might be difficulties with controlling impulses, memory, and vigilance or sustained attention. So we can actually use this information to potentially identify genes that might be contributing to BPD. So a lot of interesting things that don't necessarily have a clinical application, but that could eventually help us identifying causes. All right, so that is everything. I do want to acknowledge my laboratory at the University of Toronto Scarborough campus, where all this research is taking place, and my primary collaborator, Shelley McMain, and the BPD clinic at CAMH in Toronto, and this research funded by AFSP and the Canadian Institutes of Health Research. And last but not least, really this research wouldn't be possible with people actively participating in our research. And so I want to thank people with BPD, their families, who really make this research possible. That's it. Thank you.
Thank you, Dr. Rocco. We have, in addition to questions, we have compliments both to you and Dr. Balf for these very wonderful, informative discussions. I've got a big stack of questions I'll start going through. There's some overlapping questions, and some of these we could also bring to the panel at the end. We'll start with, I've always worked with the assumption that stress anxiety impairs cognition. Do you know of any research looking at fluctuation in cognitive functioning related to stress affective states? And then the question goes on, but let's start there.
Yeah, it's a really great question. The reason it's so important is because, unfortunately, right now, all these standardized tests that we use as clinical neuropsychologists, they don't really get at the heart of what's going on with BPD, frankly. You know, that under conditions of stress, that's often when cognition is most significantly impacted. So what I'll say in terms of research out there right now, there are a few studies that try to integrate emotion with some of these cognitive tests. For the most part, the results haven't been that fruitful. I think the reason is that, you know, having somebody try to draw something, for example, that's very emotional from memory isn't really what's going on. I think that inducing a mood, you know, being able to get greater, being able to go into the real world and seeing what's going on with cognition when people are emotionally dysregulated is what we need to do. So what I will say quickly, though, is that in my laboratory at the University of Toronto, we actually have a brain imaging device that is not an MRI, okay? It actually is slapped onto the person's forehead. Well, not slapped on, but, you know, put onto the person's forehead. Nobody's going to want to be in my research now after I said that. But what we can do is actually, and it uses infrared light, I should say, to image the brain. You can actually then have the data that's, you know, while you're imaging the brain, downloaded to your iPhone if you really wanted to, and be able to follow somebody in their everyday life. So this is the kind of research that we're going to be doing over the next few years, trying to understand how this might be playing out in the real world.
There is a question about, could you describe what memory aids are to aid a client, to help a client with BPD, with cognitive deficits?
So another very good question. There are actually people working on and there's actually a lot of work done with schizophrenia, actually, and memory, and how we can improve treatment adherence, so making sure you take your medications. So some things, really it's common sense stuff, you know, and things like, you know, I actually haven't been involved in psychotherapy for a few years now as a neuropsychologist. What I can say that I've heard people do is, you know, writing things down, you know, at the end of a psychotherapy session. In the next session, reviewing what has been done. Really, memory aids can be things like even pill boxes that people use to remember to take medications. Usually we think of this associated with like Alzheimer's disease. But if it helps, you know? So really pragmatic things. Usually it just comes down to writing things down and reviewing things. The thing that I said earlier is that we know that people with BPD, even though they might have a hard time recalling information, it's in there. So as long as you can find a cue to help the person remember the skill or whatever it might be, they usually are able to retrieve it from their memory. So it's not that they're completely forgetting things. It's in there. It's just trying to use some cue so that they can use to recognize what skill they should be using or what the memory was that they've actually stored. So I hope that helps, but we actually need more research done in this area in terms of what would be helpful for BPD.
This one is, you've discussed the neurocognitive deficits in borderline personality disorder, but how do you tease out the impact of neurocognitive problems due to other comorbid disorders? For example, in case number 2, could it be related to the alcohol abuse?
So it's another very good question. And I feel like you're all reviewers of my papers right now. But it's a very good question. So one issue with the research that's done in this area is that we don't have large enough sample sizes to say, okay, let's look at these people who have, no substance abuse history and those that do, and comparing their cognitive functioning. So the research that we're doing now, we're trying to get the largest sample that's ever been studied. So we want to have at least 100 people tested. Right now we're at about 60. So we can actually tease these things apart. What I will say is that there have been questions about substance use disorders and PTSD. And the research suggests that in terms of substance use, these probably are these people who have extensive histories of, let's say, alcohol dependence or cocaine dependence. These are the types of drugs or substances that tend to be associated with worse cognitive functioning. But I should say that once somebody abstains from a lot of these substances for a long enough period of time, cognition tends to go back to normal, So we don't expect that unless somebody is currently has one of these disorders that they would be affecting these people. And all the research that we do, we actually screen people out who have these disorders currently. In a way, it's actually a good thing because these people say, I really want to be in your research, so they'll actually abstain for a month, and it actually is kind of the start to them getting on the road to recovery with that in that respect. And I'll say about PTSD, the jury's still out, but it overlaps a lot. The neuropsychological profile in PTSD overlaps a lot with BPD, and we still need more research on this topic. I wish I could give you an answer, but not just yet.
This question is, how do the visual spatial impairments in BPD affect their behavior? Would it be different than individuals who have visual spatial impairments but without BPD?
I actually have never thought of this, so it's a good question. Because when I think about visual spatial abilities, I was surprised that they're even impacted here, right? What I would say is that executive functions actually do play a role in visual spatial abilities. So if you think about navigating your way like I did from the New Haven Hotel here, you do need to be able to use your problem-solving abilities. You need to be able to use a lot of these complex thinking abilities to be able to navigate, to where we are today. So I think that it's probably other functions that are related to visual spatial abilities that are actually having an impact. And that's very different from somebody who maybe had a stroke that ends up really affecting very strongly visual spatial abilities. When I see patients with dementias and different types of brain insults, they will actually have difficulties. If I say, would you like to go to the cafeteria for lunch now, I need to actually walk them over because they actually wouldn't be able to orient themselves in space appropriately, especially the more severe ones. So it's a little different. I would associate the BPD visual spatial problems more to the problem-solving abilities rather than what we see in actual disorientation in space.
This is a question. Can you comment on dissociation as a cognitive deficit, perhaps in relation to some of these memory deficits?
Yeah. So you know what? The research that I've started to see coming out that's not published yet, but that I've reviewed, actually does suggest that those who have dissociation might actually be the worst off neurocognitively. We don't have enough data on that just yet, but that is the research that's starting to come out. What is going on with dissociation? What's causing it? I'm not sure that that's 100% clear just yet. What I would say is that the people who have dissociation, the more severe dissociation, tend to be those who describe the worst difficulties with cognition, and when we test them, it's confirmed through that. Yeah.
Can you describe response inhibition? And then there's another question about, for case 2, is it possible the memory deficits are actually deficits in response inhibition?
So in terms of response inhibition, I did actually update these slides and didn't actually provide them here. What I actually presented was a test, this test called the Conners Continuous Performance Test, where somebody needs to look at a computer screen, and every time they see a letter of the alphabet, which can be any letter of the alphabet, they need to press the space bar. So it sounds pretty simple, but these things come up on the screen pretty quickly. People don't like me when I ask them to do this test, I'll tell you right now. And what they have to do, though, is every time they see the letter X, they have to not press the space bar. They have to stop themselves. That's the way that we measure response inhibition, one of the ways that we measure response inhibition in our laboratory. So it's, can you stop yourself from doing something that you're inclined to do? So we asked somebody to do this type of a test, not just for 2 or 3 minutes. We asked them to do it for over 10 minutes, okay? Sometimes people are dozing off. Some people, are getting really angry at me. Well, thankfully, it's my research assistants who are doing it and not me anymore. But this is what we mean by response inhibition. So response inhibition definitely plays a role in lots of other cognitive functions. I should say that some people are just off the charts. I mean, I showed you people who have pretty reasonable neuropsychological profiles. Some people's Z-scores are just way off the charts on that test specifically. They literally cannot stop themselves from pressing that button. So in the person that, the second case, in terms of how response inhibition might actually be impacting memory, what I would say is that for the test that we use for memory, it's like a shopping list, okay? We'll actually give somebody a shopping list. And we don't think that the ability to control yourself necessarily plays a role in your ability to just kind of recall your shopping list, right? But it's possible maybe in that moment that that person is really anxious and they're having a hard time inhibiting their mood or kind of regulating their mood, and that's interfering with their memory. So I can see how maybe problems with emotion regulation could be actually impacting a lot of what's going on here. When you present somebody with a huge list of words, they usually get anxious, So if you have a hard time controlling that anxiety, then I wouldn't be surprised if you're not doing as well as you could be on that test.
Are there any simple verbal memory tests that could be used in outpatient offices for providers?
A very good question. And so actually, there are some very straightforward tests that are out there. I would recommend something like the Hopkins Verbal Learning Test. That's one that I'm actually talking about, almost like a shopping list in a way. It has 12 words on it and 3 learning trials, and it's a really interesting test. What I will say is you're not going to detect these memory problems using the mini mental state examination. 3 words is just not enough in order to evaluate this. It's just not sensitive enough. And so I would recommend definitely using a test that's more extensive than, kind of a simple, brief memory test. And one of them, as I said, is called the Hopkins Verbal Learning Test. A longer test, if you really want to go there, is called the California Verbal Learning Test. And that has 16 words and lots of other fun things that your patients will not like you asking them to do. I don't like doing them.
What are effort testing profiles like in neuropsych testing with individuals with BPD? Are there high failure rates?
Very good question, because I actually am writing a paper on this right now. And this is what I found. I found that in 50 people with BPD who are outpatients, what I found is that 10% of them have questionable performance. So we don't really know why there's questionable performance, what their motivation is. I think it's just that they maybe are having a hard time concentrating or something like that on these tests, but they really are tests of effort. So what I would say is that most people are trying. And the reason I think that question is so important is because so many clinicians, the stigma out there is that these people are manipulating you, they're untreatable. But in fact, if we look at our tests, our objective tests are actually showing that they're trying. They're not there trying to, pull a fast one. I've got memory problems, but I really don't, if you test me. We're finding that there really are, they're trying on these tests. And I think that alone will go a long way, I hope, toward reducing stigma, that they're trying. And in my research protocol, the people who aren't trying are healthy controls, actually. We're finding that people are just saying, oh yeah, I want to be in your research, and then they end up failing our tests because they just want the money from us. So it's actually our healthy people who are failing the test more frequently than our people with BPD.
Does your practice diagnose borderline personality disorder from neuropsych testing?
So that's a really good question because I've gotten emails about this. So I actually am not involved in clinical practice. All of this is really related to the DBT clinic and mainly for research. What I will say, though, is that no neuropsychological profile is diagnostic. I know a lot of people like to say, okay, look, my neuropsychological profile looks like that. But there are a lot of people who have depression or who have no mental health history, issues at all, and they might look like two, actually. So it's never diagnostic. Even for somebody with Alzheimer's disease, it's not diagnostic. So what it does is it's descriptive. It tells us what are some problems that people might have, and is it consistent with what we know about people who have this diagnosis? I like to use it, as I said, for treatment planning, and also to assist with diagnosing things like ADHD and learning disorders, because neuropsychological testing is part of the diagnosis of that.
How might cognitive deficits impact interpersonal relationships?
Yes. So one of my students is actually looking at another aspect of cognition that I'm not even talking about today. It has to do with processing emotions in faces. And when I presented this research in Boston 2 weeks ago, family members were saying, you need to get the word out there about this. What our main finding was this. People with BPD looking at faces actually process neutral faces in a very different way than people who don't have BPD. They tend to actually see a negative emotion in a neutral face. And we actually found that they have a hard time recognizing disgust in faces, which is interesting considering disgust signifies rejection, and anger as well. So a different aspect of cognition, it's a social cognition. So I think that some of these things are contributing to how people are actually interpreting social cues like faces. So the research is suggesting that actually something that's unique to BPD that you don't see in schizophrenia, bipolar disorder, because I've actually done research on this in those disorders, is misinterpretation of neutral faces. And difficulty really identifying and recognizing faces that are signifying threat or rejection.
How can a treater or family member address these problems in perception cognition without seeming to invalidate the experience of someone with borderline, given that feeling invalidated may lead to more dysregulation?
Yeah, it's a good question, and I have to give credit to the therapists out there who, really are trying to manage emotion dysregulation on the one hand, and then also, cognitive dysfunction. I've found that, in my training, validating that these are real experiences, that if you're having memory problems, to validate it, this is a real experience. Something I didn't even get into here is that think of the average BPD person. You've got somebody who's got high IQ, generally speaking. Even if their memory is in the average range, let's say it's low in the average range. If you have a really high IQ, you're going to experience that as a memory problem. So I think it's important to keep in mind that people with BPD tend to have high IQs, okay? As I said, my research is actually a little bit higher for BPD versus our healthy individuals. But if their memory is average, they experience that as a memory problem. So validating that, maybe even pointing out that you can have a high IQ and an average memory, and for you, that might actually be experienced as a memory problem. And to work on it, I think to acknowledge it is the first step in validating it and trying to work in some of these memory aids or whatever it might be in treatment. And hopefully we'll have some more empirical support for types of aids you can use in treatment in the future. Right now, we don't really have the science supporting it.
A final question before our break. You mentioned that all patients with BPD do not have the same cognitive deficits. Is there any evidence that there are clusters within BPD, perhaps indicating that what we call BPD is actually several distinct disorders lumped together?
Mm-hmm. Yeah, and this is the reason that I talk about having a large enough, when you're doing studies, sample size, right? Fortunately, unfortunately, I'm not sure what to say here, in Toronto, we have so many people with BPD and their family members who want to be in our research. Part of it is because of the lack of access to treatment and people really wanting to be able to do something. So we're really fortunate, I have to say, to have so many people interested in the research, and this is why I have this slide here. When we have enough people in our research, we can actually try to identify subgroups. And I know it's not the topic of today's presentation, but when I talk about these different profiles in family members and controls, the research that I've done actually suggests that those who have the worst impulse control problems based on neuropsych testing in terms of people with BPD, their relatives are more likely to also have really bad impulse control problems using the tests that I've talked about. And this is a suggestion that maybe there's a subgroup of people where response inhibition, impulse control, is a core inheritable component of the disorder. And maybe there are other aspects of cognition, memory, attention, that differentiate these people from another group of people where these are the main problems. So this is why I talk about going beyond clinical uses. We can actually use these cognitive deficits and brain imaging markers as ways to maybe figure out if there are subgroups of people with BPD. And I think most people would agree there probably are. And if you look at the research on autism spectrum disorders, schizophrenia, the research is showing once you go down to this level, beyond symptoms, going down to cognitive functioning and brain imaging, you see subgroups of people that are probably related to different causes for the disorder. And that's the way that I use these types of tests in my laboratory.
Thank you, Dr. Rocco.
No problem.